Greetings from the Tender Palm Super Speciality Hospital. Today,
Doing a case of M-Teer in Tender Palm Super Speciality Hospital. I will give you the brief history of this patient. This is a 53-year female. This patient is basically dilated cardiomyopathy with LBB. QRS duration is very much wide. It was like 238 probably, and she presented with us with recurrent VT. Ejection fraction was 25%. 1.5 months back, we have decided to do the CIT-D implantation for this lady. We implanted CIT-D 1.5 months back. She was symptomatically better, but the MR was still persisting. We get an MRI done. MRI shows that the akinetic thin LED territory and the fixed defect of the perfusion and severe MR. So it was proved that this is not going to help. CIT is not going to help much with this regression of MR. So we observed this patient quite a days back and continuously following it. And after 1.5 years, half month of the follow-up, we decided to go for the tear therapy to this patient. So we are doing today with the MyClip tear to this patient. We have recorded the echo for you, and Dr. Hemant is going to describe the echo for you. So Dr. Hemant, please describe the echo.
We can see that this is a very similar landmark, but this is also actually it's the 19 number, and you can see there is a PML is a restricted one, and the length of the aim and the PML we have measured. That's aim length is it's around 11 mm, and the PML length is around
So the PML length is around 9 mm, and you can see that there is a restricted movement of the mobility of the PML and the previous one, and you can see that this is the length of the PML. It's a 9 mm, and you can see that the coaptation length is around 3 mm. That is sufficient for us. For the next, you can see here. You can see that in the pulmonary vein systolic flow damping is seen, that shows the severity of the MR again. And here you can see that the mitral valve inflow, there is no significant gradient. The initial gradient of before pre-procedure is around 0.52 millimeter of mercury. So there is no significant, while opening is fine. Here you can see that this is the 3D NFAS view. You can see there is a clearly, you can see there is a A2P2 MR, the severe jet coming from the A2P2 scallop, and here is the mitral valve area by the 3D planimetry area, that is it's around 3.2 3.5 square centimeter. That is sufficient for us. So here you can see there this is a sweep. In the lateral sweep, you can see we can see that there is a significant MR. In the central one, you can see this is the MR, and in the medial one there is no significant MR. Okay. So basically, we are going for first for the septal puncture. Now over to the Dr. Gautam.
So this is the clear-cut case of the FMR with the A2P2 gap, and the MR jet is basically exiting out from the A2P2. So now we will plan the case. I will describe you the basic step of this case. So we will go step by step. First we will do the septal puncture. The ideal site of the puncture will be more mid and the posterior, and then we will enter into the LA with the this bullseye sheath, and then we will insert the MDC into it, and then we will direct MDC towards the mitral valve, and then we above the mitral valve we will position the this MyClip, and then we will dive into the LV. We will keep this position, and then we will grab the mitral valve leaflet, and then we will assess the same things that Dr. Hemant has presented in front of you. We will assess the how much we will reduce the MR, and probably we will leave some MR there because it will actually protect the LV from the sudden mismatch of the preload and afterload. So this will be the flow of a step. We will start the case, and then at the end of the case we will again demonstrate you the the various steps of the MyClip procedure.
हल्का सा और
Okay, I think it's good.
so little bit more
Okay.
I'll be at ridge, that will be okay for me. Yeah, yes, this is good, sir. Can you measure the height? It's quite better, sir.
3.7,
It's quite better.
3.8. It's
Yeah,
good.
it's good. We can go, sir. Can you come
Yeah.
to short access?
Yes. Coming. Yes.
Yes, we can go in, sir. आप push कर दीजिए. Steady push, steady push.
It looks like the sector is released.
Yeah,
There is no tenting.
but I'm not so sure whether we are in or not. Now push it in, sir. यहाँ पे push कीजिए.
You are in. Yes, you are in.
Yeah, we are in. Push the needle. Push the sheath, sir. Push the sheath. Push the sheath.
Okay.
वो सीट फोल्ड करो हमेशा ऑलवेज सीट पे याद रखिए हाँ चलो
चलो पुश करो भाई.
Now you can align the lines.
अब इसमें ये लाइन पे सकते
सर थोड़ा पोस्टीरियर टॉप दीजिए गाड़ी पे.
ये इंटीरियर अपनी तरफ
More.
ये पिक्चर है ना ये अपनी ठीक है अपनी क्लिप है ये
You can advance it, sir.
Yes, yes, yes.
Advance it a little bit more. Pull it back, sir. Little bit. Gautam, sir, थोड़ा सा बस perfect. Now you can sandwich the clip, sir. Now you can sandwich the clip.
Yes.
You are in upper pulmonary. Near to upper pulmonary.
Because you are too much in.
Can you go a little anterior, sir?
Taking.
Now go ahead, sir. Go ahead. Can you?
मैं कंटिन्यू कर रहा हूँ एम को.
Okay, okay, okay.
आप पूरा पोस्टीरियर चलिए पेन, sir. Thank you, sir. You go to grasp unlock the clip. Open the clip. So can you throw
Yes.
ready?
Again,
Can you place color on this?
yes.
Hemant sir, we are opening the clip. Can
Okay.
you just check in 3D and fast? 305 is
You want to see in the 3D?
Yeah.
Going.
We'll dive in, sir.
Okay.
Okay.
Close 60. अभी तो 60 कहाँ देखिए?
ये कम होगा ना सर?
कम हो गया ना, वो अपोजिट डायरेक्शन में जाना है.
Perfect. We are 60. We are 60. PDF पे भी देखिए.
हाँ.
Current center.
Yes. रोटेट मत कीजिए, आप पहले चले जाइए फिर रोटेट कर लीजिए. चलिए आइए सर, आप एंट्री आते हैं थोड़ा सा. पुल सर, पुल इट मोर, पुल इट.
Yes, it's good. Both are rested on the clips.
Yeah, now it is good.
Yes.
I'm quite. So you can start your assessment from 0 to LVOT.
Okay.
Done, sir. Done.
Sure.
Yeah, perfect, sir. I'm pulling it out.
Yes. Okay. Out. Out. It's out.
So we started with the puncture. So we took the SL1 sheath and the broken bone needle, and we just saw the echo, and the bicable we supposed to be mid to inferior, and short axis we supposed to be more posterior. So Dr. Hemant, can we see that echo? Yeah. So you can appreciate here we are basically drawing down towards the IVC, and this is the tenting. You can appreciate here, this is a good position for puncture. You can see we are more posterior, we are more away towards the aorta. This is the tenting, and we just puncture the septum at this point. We measure the distance. Distance was actually around 3.9. So it is a good distance for ideal puncture of the MyClip. Next, sir. So can we see here in the fluoro? We just steer the sheath. This is the Agilist sheath we have. We steer the sheath into the LA and place into the comfortable position. That is again we are seeing into the this echocardiogram. So we took the two wires over there. One is the employed super stiff wire, and second one is the pigtail catheter. Pigtail catheter is just to measure the LA pressure, and the super stiff wire basically used to guide this MDC. So we took we serial dilate to the groin, to the 20F sheet, and then we took the MDC over here. You can see MDC is going in, and just we withdraw the dilator slowly. We just take care that the MDC shouldn't suck any air. So we make it air free system, and then we deliver the MyClip. So the next step is to doing the sandwiching. So sandwiching is the method in which we are sure that our MyClip system will not injure to any surrounding structure. Once we ensure that this sandwiching, then we started giving M. So M is to just giving the curvature to the MyClip delivery system. You can appreciate over here that we are giving M, and we are seeing the same thing into the two view. One is the bicommissural view, and then we having the LVOT view. In the bicommissural view, we can assess the medial and lateral position of MyClip, and in the LVOT view we can assess the this anterior and posterior position of the MyClip. So idea is to keep this MyClip into the center and the arm is open. Actually we open the arm and place the above the level of the mitral valve. So this you can appreciate in the fluoroscopy. We open the arm 120 degree and we just analyze that the should our position of the MyClip in the optimal or not. So the optimal position in this case is around basically 12 o'clock to 6 o'clock. So by manipulating the delivery system, delivery catheter, MyClip delivery catheter, we just take it anterior, posterior as well as medial and lateral. We position the MyClip into the 12 and 6 o'clock position. You can appreciate that our MyClip is at the 12 and 6 o'clock position. This is the good position to dive into the LV. Then we closed the arm of the MyClip delivery MyClip. You can appreciate that we have closed arm to the 60 degree and this is the time to dive into the LV. Next please. Now with the 60 degree angle we are diving into the LV and we simultaneously see the echocardiogram so that our both arms should lie onto the this anterior and the posterior mitral leaflet. So you can appreciate here that our both arms are resting at the both arm of the MyClip. Anterior and posterior mitral leaflet are comfortably sitting at this position, means this position is good. We are good here to basically down the grasper of the MyClip. So we just down the grasper of the MyClip. Can we see here please? Give this MyClip grasper down and simultaneously we assess the parameters on the echocardiogram that where our grasper are in a good position and we are bisecting the jet of the mitral regurgitation. We have seen that we have the mean gradient is 1.48, that is mean we didn't create any significant mitral stenosis because it is almost like before the procedures. Simultaneously we have seen the jet, there is a minimum jet. We have also seen the pulmonary venous flow here and we have seen that the previous before the MyClip the flow was actually blunt, but here there is only systolic flow. Simultaneously we have also observed that our both the arm of the MyClip delivery system has bisected the jet and now we are seeing two jets. In fact there is a very much trivial or mild MR that is left and that is again being left because of the hemodynamics of the this LV, because if we close completely there should be a large mismatch of the preload and afterload. Here we again saw the various parameters. We again saw the pulmonary venous flow. It is very good. We are happy with that. Next. So this is the final picture and this is the 3D in phase view in which we are seeing that the leaflet are both the leaflet are grasped by the MyClip and they are moving very good. And now it is time to release the MyClip. So you can see here this is the release of the MyClip here. Now we have released the MyClip. Parameters are good, pressures are good. We don't need any vasopressor support to this patient and we are just giving him some dobutamine just to facilitate the LV. So I think we have successfully done the MyClip case. This is the first case of the MyClip in Uttar Pradesh. And me and my team, Dr. Mohit, Dr. Adesh and Dr. Krishna is here, our technical team is here. I am thankful to my colleagues that they have supported me in this case. I am thankful to our critical care team as well. So this is all from the Tender Palm Super Specialty Hospital. Thank you very much.